Most people over 65 are told the same thing about knee pain. It's arthritis, take something for it, and try to stay off it. It sounds sensible. It sounds safe. But here is what nobody tells you. Calling every aching knee arthritis does not protect your ability to climb your own stairs. Arthritis is real, and it is common. It is also the easiest answer in a very short appointment. Orthopedic clinics see this every single day. A person arrives with knee pain, an X-ray shows some joint wear, and the wear gets blamed for all of it. Here is the part that surprises people. Imaging studies have consistently found joint changes on X-ray in a large share of older adults who have no knee pain at all. So wear on a picture does not automatically explain the pain you feel when you stand up. Over the next few minutes, I am going to walk you through 5 contributors to knee pain after 65 that often get skipped when arthritis is written down first. Each one comes with something specific you can safely start on your own, and something specific to ask your own doctor. The number one item on this list is something almost nobody talks about, and it is not in your knee at all. Stay with me until the end, because that one can change how you approach the next 10 years. Let me tell you why this gets missed. And it is not because anyone is careless. The average appointment is about 12 minutes. In 12 minutes, a doctor has to hear your story, examine you, address your blood pressure, review your medications, and write everything down. 12 minutes is enough to identify the most likely cause. It is rarely enough to sort out the 3 or 4 things stacked on top of it. So the most likely cause gets the label, and the rest goes unexamined. I am not here to sell you a supplement or scare you into a course. This channel exists to give you the science a 12-minute appointment never has time to cover. I have nothing to prescribe you and nothing to ship you. What I have is time to explain the things that get compressed out of a short visit. Here is what is actually at stake. Knee pain is one of the most common reasons older adults stop walking distances, stop taking stairs, and start planning their day around what hurts. That is not a comfort issue. That is the first step toward needing help to get out of a chair, and eventually needing help to stay in your own home. Tell me in the comments how old you are and what part of the country you are in. I read these, and the pattern in your answers tells me what to cover next. Now here is the one mechanism that ties all 5 of these together, and I want you to hold on to it. Your knee is not really a hinge, it is a load transfer station. Every step you take sends force up from the ground and down from your body weight, and the knee's job is to pass that force along without absorbing more than its share. Think of it like a bridge in a road network. When a bridge cracks, the obvious question is whether the bridge is weak. But engineers ask a second question. Is this bridge carrying traffic that was supposed to go somewhere else? A bridge under twice its intended load will crack no matter how well it was built. Fix only the concrete and it will crack again. Every cause on this list is really a story about traffic being routed onto your knee that belongs somewhere else. Please do not skip this section. It is the key to everything that follows. If this is already making sense to you, tap the like button so more seniors can find it. Cause number 5 is a stiff ankle. Specifically, limited upward flexion at the ankle. The motion that lets your shin travel forward over your foot when you step. Here is why that lands in your knee. When you take a step or lower yourself into a chair, your shin needs to tip forward over your ankle. If the ankle will not give you that range, your body still has to get down, so it borrows the motion from the joint above. That joint is your knee. Back to the bridge. A closed exit ramp does not reduce the traffic. It just sends every car onto the next bridge down the road. The ankle stops absorbing its share, and the knee absorbs it instead, every single step, thousands of times a day. Research on older adults has repeatedly linked reduced ankle motion to altered walking mechanics and increased load at the knee. This is one of the better established relationships in gait research. Here is the protocol. Stand facing a wall, about an arm's length away, with your hands flat on it. Put one foot forward, toes about 4 inches from the wall, and keep that heel flat on the floor the entire time. Slowly drive that knee straight forward toward the wall until you feel a stretch in the back of the ankle. Hold for 20 seconds, then release. Do 5 holds on each side, twice a day, morning and evening. Progress by moving your toes half an inch further from the wall each week, only if the heel still stays down. The mistake almost everyone makes is letting the heel lift. The moment that heel comes up, the stretch stops reaching the tissue you are trying to change. Keep both hands on the wall the whole time so the wall is carrying your balance, not your legs. Do this next to a counter if a wall feels unstable to you. If you feel sharp pain in the front of the ankle, stop. Sharp pain means stop. not push through. A pulling sensation in the back of the ankle is what you are looking for. Pair this with sitting less. Ankle range tightens fastest in people who sit for long stretches, because a seated ankle sits in a shortened position for hours. So do the wall stretch right after you have been sitting, because that is when the tissue is at its tightest and has the most to gain. Now, a stiff ankle changes how force arrives at your knee, but it does nothing about what happens once that force gets there, and that depends entirely on whether anything is there to absorb it. Which brings me to cause number 4. Cause number 4 is weakness in the muscle on the front of your thigh, the quadriceps. This muscle is your knee's shock absorber. Every time you lower yourself into a chair or step down from a curb, the quadriceps lengthens under tension and slows your descent. When it is strong, the muscle eats most of that force. When it is weak, the force goes straight through to the joint surfaces. Picture the suspension on a car going over a pothole. Good suspension absorbs the hit, and the frame barely notices. Worn suspension passes the whole jolt into the frame. Your quadriceps is that suspension, and after 65 it weakens faster than almost any other muscle in the body. Large clinical trials have consistently shown that strengthening the quadriceps reduces knee pain and improves function in older adults. This is among the most reliably reproduced findings in the entire knee literature. Here is the protocol. Sit in a firm dining chair with your back supported and both feet flat. Straighten one leg out in front of you until it is level with your hip, and hold it there for 5 seconds while you squeeze the front of the thigh. Lower it slowly over a count of 3. The slow lowering is where most of the benefit lives. Do 10 repetitions on each leg, and do that 3 days a week with a rest day in between, because muscle rebuilds on the rest day, not the working day. Progress by adding a second set after 2 weeks, then by wearing a shoe on the working foot for a little extra weight. The mistake people make is dropping the leg fast instead of lowering it, which throws away most of the value of the exercise. Use a chair with arms if you have one, and rest your hands on them. Never do this on a soft couch, because a sinking seat changes the angle and puts your knee in a position you cannot control. If you feel a sharp catch inside the joint, stop for that day. Aching in the muscle afterward is normal and expected. Sharp pain inside the knee is not. Pair this with protein at the same meal you do it, because muscle built from training needs material to build with. 25 to 30 grams of protein at breakfast supports what the exercise starts. Training without protein is ordering the construction crew without delivering the bricks. Strength gives your knee something to absorb force with, but strength is built on top of tissue, and tissue after 65 is quietly being changed by something most people never connect to their knees at all. That is cause number 3. Cause number 3 is a medication side effect, and specifically the joint and muscle pain that can accompany certain commonly prescribed drugs. Here is the mechanism. Some drug classes used widely in this age group can produce muscle aching or joint discomfort as a recognized side effect. When that happens in a person who is 65 and already has some wear on an X-ray, the pain gets attributed to the wear, because the wear is visible and the side effect is not. Back to our bridge. This is traffic that was never on the road until a new on-ramp opened, but nobody checks the date the ramp was built. The tell is timing. Pain that appeared or clearly worsened within weeks or months of starting or increasing a medication is a timing pattern worth putting in front of your doctor. This is well documented in prescribing information for several common drug classes, which is exactly why it belongs on your list of questions rather than in your own hands. Here is the protocol, and this one is entirely about information, not action. Write down every prescription and over-the-counter product you take, with the dose and the month you started it. Next to that, write the month your knee pain started or clearly got worse. Bring both lists to your next appointment and ask one specific question. Could any of these contribute to joint or muscle pain, and does the timing fit? Do this before your next visit, not during it, because nobody reconstructs 2 years of medication history in a 12-minute appointment. Update the list every time something changes. The mistake people make is describing their medications from memory, which produces a vague conversation instead of a specific one. I want to be very clear about the safe way to use this. Never stop or change a prescription on your own based on a video, including this one. If you take a cholesterol medication or any long-term prescription, talk to your doctor before changing anything. Your only job here is to bring the timing to someone who can evaluate it. That is the stop condition on this item. You gather, they decide. Pair this with bringing one written question rather than 5 spoken ones, because a single specific question survives a short appointment and a long list does not. Ask the timing question first, before anything else, because it is the one that reframes everything that follows. Medication timing explains pain that arrived from the outside. But some knee pain is not coming from the knee at all. It is being felt there while it starts somewhere else entirely. That is cause number 2. Cause number 2 is referred pain from the hip. Here is the mechanism. The hip and the knee share nerve supply from the same segments of the spine, which means the brain can receive a signal from the hip and locate it at the knee. This is not unusual or exotic. It is a well-recognized pattern, and it is the reason a genuinely arthritic hip can announce itself as knee pain and nothing else. Think of it like a doorbell wired to the wrong room. The button at the front door works perfectly, but the chime rings in the kitchen, so you keep checking the kitchen. The pain is real. The location is misleading. Clinicians are specifically trained to look for this, because hip problems presenting as knee pain are common enough to be a standard teaching point. Here is the protocol, and again it is diagnostic information for your doctor rather than a treatment. For 1 week, note 3 things each time your knee hurts. Whether the pain sits in the front of the knee or feels deep and hard to point to, whether it worsens when you put on socks or get out of a car, and whether you feel anything at all in your groin or the side of your hip. Write it down the same day, not at the end of the week, because memory smooths out exactly the details that matter. Bring that week of notes to your appointment and ask directly whether your hip should be examined. Pain you cannot point to with one finger is the pattern worth reporting. The mistake people make is only mentioning the knee, because the knee is what hurts, and so the hip never gets examined. There is nothing to push through here and nothing to stretch. If you notice pain in the groin or trouble putting on shoes and socks, treat that as information to report rather than a problem to work on yourself. Do not start hip stretches from the internet while the cause is still unknown, because stretching an irritated hip can make it worse. Pair this with the medication timeline from the last item. Bring both to the same appointment, because together they answer the 2 questions a rushed visit almost never gets to. When did this start, and where is it actually coming from? So far, every cause has been about the knee, or about something feeding into the knee, but the one that matters most is not a structure at all, and it is the reason the other 4 keep coming back even after people address them. That is number 1, because number 1 is deconditioning of the whole movement chain. What happens when the body quietly reorganizes itself around avoiding pain? Here is the mechanism, and this is the deepest one on the list. When a knee hurts, you protect it without deciding to. You take the stairs less. You stand up using your arms. You shift your weight to the other leg without noticing you have done it. Every one of those adjustments is sensible in the moment and costly over months. The muscles you stopped using get weaker. The joints you stopped moving through get stiffer. The other knee starts taking traffic it was not designed for. Back to the bridge one last time. When one bridge gets flagged, traffic reroutes. 6 months later, the neighboring bridges are cracking. The original bridge has decayed from disuse, and the whole network is weaker than when the problem was one bridge. That is deconditioning. It is not a knee problem. It is a network problem that started at the knee. This is why the other 4 items on this list keep returning. You can stretch the ankle, strengthen the quadriceps, sort out the medications, and check the hip. And if the overall pattern of protection stays in place, the pain finds its way back. Large bodies of research on older adults have consistently found that reduced activity and protective movement patterns predict further loss of function, and that the relationship runs in both directions. Pain reduces movement, and reduced movement increases pain. This loop is one of the most consistently documented findings in geriatric rehabilitation. Here is the protocol, and it is deliberately unimpressive. Pick one movement you have quietly stopped doing and do a small amount of it every day. If it is stairs, take 2 stairs up and 2 down, holding the rail once a day. If it is standing from a chair, stand up and sit down 5 times without using your hands, or with one hand if you need it. If it is walking, walk to the end of your driveway and back, every day, regardless of weather. Do it daily rather than 3 times a week, because this item is about reversing a habit, and habits respond to frequency more than intensity. Add exactly 1 repetition per week, not more. In 8 weeks, 2 stairs becomes 10, and 10 stairs is a different life than 2. The mistake people make is starting with 20 on a good day, hurting for 3 days afterward, and concluding that movement is the problem. Every one of these gets a rail, a counter, or a chair back within reach, without exception. Stand next to the rail even on the days you do not think you need it. If your knee pain is clearly worse the next morning, you did too much yesterday. Go back to the amount that did not do that and stay there an extra week. Mild aching during the movement that settles within an hour is acceptable. Pain that lingers overnight is your signal to reduce, not to stop entirely. And if any of this produces sharp pain, swelling, or your knee giving way, stop and call your doctor. Pair this with the number from cause number 4. Do your daily movement, then eat protein within the hour. Movement is the signal to rebuild, and protein is the material. You need both, and most people over 65 are quietly short on the second one. Here is what I promised you at the start. The reason almost nobody talks about this one is that it is invisible. There is no scan for it, no blood test, no line on an X-ray, and nothing to prescribe. It only shows up as a slow narrowing of what a person does, one small avoidance at a time, until the world gets smaller and everyone calls it aging. That narrowing is the thing that actually decides the next 10 years, and it is the one item on this list that responds almost entirely to what you do on ordinary days. Consider a typical case documented in the rehabilitation literature. A 74-year-old woman who had been told for 3 years that her knee pain was arthritis. She had stopped taking stairs, was using her arms to stand, and had cut her daily walk from 20 minutes to 5. An X-ray showed moderate joint wear, which everyone assumed explained everything. She had also gained the habit of avoiding her left leg entirely without being aware of it. Her care team worked through the same territory we just covered. Her ankle range was limited, so she started the wall stretch twice daily. Her quadriceps had measurably weakened on the painful side, so she began seated leg extensions 3 days a week. Her medication timeline was reviewed with her physician. Most importantly, she picked one avoided movement, standing from a chair without her hands, and did 5 every single day. The change was gradual and unremarkable week to week. By 12 weeks, she was standing from a chair without pushing off and had returned to a 15-minute daily walk. Her X-ray had not changed at all, because X-rays rarely do. What changed was how much of her body was participating. So here is exactly what to do. Tonight, do 1 wall ankle stretch, 5 holds of 20 seconds on each side, holding the wall the whole time. Tonight, also write down every medication you take with the month you started it and the month your knee pain began. This week, start seated leg extensions, 10 each leg, 3 days apart, lowering slowly over a count of 3. This week, spend 7 days noting whether your pain is sharp and pointable or deep and vague, and whether anything shows up in your groin or hip. And starting tomorrow, pick one movement you have been avoiding and do a small amount of it every single day, adding 1 repetition per week and no more. Balance is not luck. Mobility is not genetics. Independence is trained. Think of someone in your life who has been told their knee pain is just arthritis, and who has quietly stopped doing something they used to do. Send this to them. The person who most needs to hear that the label might be incomplete is usually not the one searching for it. Tell me in the comments which of these you are starting tonight. Your answers decide exactly what I cover next. And if you want more of this, the reasoning behind the advice, not just the advice, subscribe to this channel, because that is the entire reason it exists. This video is education, not a diagnosis. Your own doctor knows your history, so bring this list to your next appointment. I'm Nathan Reeves. Don't forget to subscribe and live longer.